So as John mentioned, I'm a cardiac surgeon in California. I'm not a blood expert or a hematologist or anything like that, but just a regular cardiac surgeon trying to do a good job. Disclosures, of course, I'm a speaker for HemoSonics, as well as a consultant for Edwards and a proctor for Medtronic and Intuitive. So my goals for today, to help us understand the variety of objectives and forces at play during bleeding management in cardiac surgery. Talk about the role of this Quantra device in helping us achieve optimal patient outcomes after cardiac surgery, and discuss outcomes at our institution before and after we started to use this device. So I think the environment you practice in is key in terms of how you manage bleeding. So in our particular environment, so we're about a 500-bed hospital, private hospital. We do about 800 heart cases a year. That includes the open cases as well as the transcatheter valve cases. But even though our volume is not immense, we do a high volume of complex cases. So a lot of aortic cases, redos, triple valves. I particularly do a lot of the robotic, or all the robotic cases there. So, why does this matter? So in private practice, there are no fellows, there's no resident, there's no anesthesiologist cruising around the unit with a TE probe in hand. So it's pretty much direct nurse to surgeon contact. And the team we have is 3 heart surgeons, 6 anesthesiologists, 5 perfusionists, and 9 nurses in the OR. So you say, why are you telling me this? Well, one of the main reasons is that significant post-op bleeding is not well tolerated. So if someone's chest tube starts putting out 300-400 an hour, that call is not going to the nurse practitioner and the resident and then the fellow, and then the anesthesiologist isn't doing an echo to look for tamponade. There's nothing. It's just the nurse at the bedside calling us, and we have to deal with it. So we don't have extra OR rooms and residents to take folks back down to the OR. So we need to keep things kind of clean and precise. The resources aren't there really to just do a case really, really fast, dump them in the unit, and let the team take care of all the bleeding. So we need to have a good, clean outcome postoperatively. And I think this impacts, our behavior. So with that in mind, my personal preferences, when I close a case, I want it to be dry. I don't want to hope it dries after I close up. I don't want to be worried about the chest tube output on every patient every hour after surgery. I don't want to be worried about tamponade. So if the patient's, urine output drops at 2 a.m. or their blood pressure is a little bit soft after surgery, of course, tamponade will always be on the differential, but I don't want to be saying, oh, this guy really bled, he was bleeding when I closed, now his pressure's soft, his creatinine is rising, is this tamponade, and do I have to go down that path? I don't want to be worried about a hemothorax on the chest x-ray the morning after surgery, and in my opinion, I'd rather transfuse in the OR with less total number of blood products than chase my tail post-op with giving even more transfusions. So in the past, what did I do to try to achieve this? So at other institutions, I've used TEG and ROTEM, and sometimes they worked well, but I think they're a little bit limited by their accuracy, consistency, patient to patient, and the time to get a result. I used to work in North Carolina, and we had a lot of obese patients, a lot of smokers, and a lot of just bread and butter cabbages. So bleeding wasn't as big of an issue out there. But where I am now, with the complexity of the cases we do, we have a lot of skinny patients, healthy patients. Everyone's on a supplement. Everybody's on a blood thinner. We tend to have a little bit more bleeding there. So we're really looking for a reliable, reproducible point of care test to help us manage these patients. So, when it comes down to transfusing or not, you guys probably know most of this already, but just to review, so, why is transfusing bad? Why don't we just give everybody a much blood? Well, obviously there's a cost effect, the immune effects, transfusion reactions, acute lung injury, volume overload makes you more prone to infection, and almost all the studies show an association with more transfusion and mortality. So those are the obvious ones, but these are some of the ones that are a little bit less obvious and particularly related to bleeding and having retained blood either in the mediastinum or the pleural spaces after surgery. So hemothorax, tamponade, having blood in your pericardium or not tamponade. I don't think tamponade is a binary event. Arrhythmias, almost all these patients that bleed and have a bunch of blood in their mediastinum go into AFib. And then little things like hesitation in starting anticoagulation post-op. So you did a mechanical mitral or aortic, or the patient goes into AFib and you're supposed to start some blood thinners on day 2-ish, but they bled the first day after surgery. So you may say, well, I don't want to start this yet, let me wait. And then they're at risk for a thromboembolic event. Increased length of ICU and hospital stay. So the folks who bleed, they're usually intubated a little bit longer, their volume status is a little bit off, they need more diuresis, and all that translates into longer ICU, length of stay, and hospital stay. The infectious issues like pneumonia, you're getting repeat echoes, you're getting repeat labs every 4 hours, you're getting all these chest x-rays. So all that results in increased cost as well. So with all that in mind, as heart surgeons, I wanted to talk about the different factors in play in managing bleeding. And this stuff, fortunately or unfortunately, is one of them. So heart surgery is the field, which you guys know, has intense scrutiny of outcomes. So from the Society of Thoracic Surgeons, a patient gets a urinary tract infection, or they forget to take their beta blocker before surgery, that's a big deal. That's a ding. And, that's publicly reported. In states like California and New York, there's public reporting. So you can Google right now, look up, Asad Shah, did 20 cabbages, 10 of them died in 2015. You can look up someone's outcome. So we're nervous. We want to make sure we do a tight, clean job. Hospital administration, and of course your partners. So almost every outcome we have is measured, whether it's the big stuff like mortality, the granularity of blood product usages, take back for bleeding, AFib, and length of hospital stay, length of ICU stay, and having to go back to the OR. So in our minds, when we're taking care of patients, particularly bleeding patient, all these different factors are at play. So, if I take this guy back, that's going to be my third take back this month. I'm going to look really bad. The administration is going to get mad at me. My partners are going to think I'm a hack. So all this stuff comes into mind when we're deciding, how to manage bleeding. So it kind of ties into this. So competing interests. So of course, everyone in the room, you guys, us, the nurses, anesthesia, we're all trying to do our best. But sometimes what's best, as you guys know, is oftentimes unclear. So as surgeons, most of us want a low transfusion rate, no takebacks or bleeding. We want to be the fastest heart surgeon in the hospital, and then we want to go play golf afterwards and not get called. Anesthesia, they're typically more inclined to not give blood transfusions, and they of course don't want to get it called back in. Also, you guys, I'm not going to speak for you, but you know what your interest and priorities are after heart surgery. And then of course we all know the blood bank, they just want to not give blood products pretty much no matter what. So how do we balance what to do with all those different interests in mind? So is it more important to say, hey, I did this case, or I did these 10 cases and I did 8 of them without transfusion and having an issue like this, or avoiding a bleeding complication? So this is someone's post-op day 1 chest x-ray in the morning, and they were fine overnight, no issues, but now they have this massive hemothorax on the left, and are probably going to need to go back to the operating room to clean that up. So peace of mind after heart surgery, does it matter? In my opinion, I think that late bleed or unexpected bleed where the case went well, the first 4 or 6 hours after surgery, they weren't bleeding, everything was fine. Then you get called at 2 a.m. that they suddenly started to put out 400 from their chest tube. That's pretty devastating to the surgeon, the patient, the family, the whole team. But I think if you know that if there's a particular abnormality in the coagulation system, specifically what that is, being able to treat that proactively instead of reactively once the tubes are dumping, I think that gives you peace of mind. And I think that makes it less likely to have one of these late unexpected bleeds. And I think that peace of mind, why does a surgeon's peace of mind matter? It shouldn't. But I think that peace of mind comes from knowing that that patient you just operated on is in a safer, more controlled state and better chance of having a good outcome. So to achieve that, so in the past, like I mentioned, we'd use TAG, we'd use Rotem, but about in February, during COVID times, we started to use the Quantra Hemostasis Analyzer, which is this thing. So we didn't know much about it, but we heard good things. We heard that the results are pretty fast, that you get a result within 5 to 10 minutes, and that it was able to tell you how various aspects of the clotting cascade are working at any given point in time. And the way it did this was with this new technology, which is ultrasound-based, to measure the viscoelasticity of blood. So it's probably bigger to see the device here on the monitor, but the same outputs here. So we pretty much have this cartridge. We have one in each of our ORs, and we have one in the ICU, and this cartridge, this machine, and it sits right behind the perfusionist. So during the case, the perfusionist will get a little sample of blood from the anesthesiologist and run it in this machine, and then it gives us an output like you see here, and we can go over what those shows. So it's really, really, really easy to learn. You guys could probably learn it in about 10 minutes, but what these times are. So that CTH is clot time heparinase. So pretty much if that top whole row, CTH, CT, CTR, it's measuring your clotting time. So that green range you see there and on the dial, that's the normal range. If that white arrow is above that, meaning the time is longer, that means it's taking more time to clot. So that's the factor deficiency. So if you're having that issue, that's typically the FFP arm. So, again, as a dumb surgeon mind, if that white dot is above the green line, we're thinking FFP. The CTH versus the CT, that just takes into consideration heparin. So you can actually check this while you're on bypass, and also off bypass, you check it. And that CTR is just the ratio of the two. So normally the ratio after protamine is given is just 1 or 1.1, and that's fine. But if that ratio is higher, let's say it's 1.5, then you know there's a little bit more heparin on board, and you just give a little bit touch of protamine. So simplistically, that upper right tell you if you need protamine or not, upper left tell you if you need FFP or not. And going down to the bottom, so PCS is your platelet function, same sort of thing. If it's within the green, that's great. In this case, because this is a strength measure, the higher it is, the stronger the platelet contribution to clot. So if this was really low, we're thinking, hey, we may need to give platelets. And F stands for the fibrinogen. So same sort of thing as the platelet one. If it's above the green, that means the fibrinogen contribution to clot strength is high, meaning like you won't need fibrinogen. If it's low, it means it's weaker, and then you likely want to give some cryo. So this kind of tailors what products we have in the room at the end and what products we may give in bleeding patients. So it's pretty straightforward. So how do we use this in day-to-day life? So the reason I'm here talking at a perfusionist meeting is because our perfusionists run and manage this every case. So when we get in the room in the morning for a start case, the perfusionist runs the Quantra. And then when we do our timeout, after they talk about antibiotics and beta blocker, that sort of thing, the perfusionist tells us what cannulas to use, which are usually the biggest ones possible, as you guys know. And they mention how the Quantra results show. So they'll say the platelets are in the middle, 50th percent normal, and the fibrinogen strength is just below normal. And that's kind of the initial one. So just based on that alone, if it's a big case, a redo case, old patient, and they tell me the platelets and fibrinogen are both low, then right away I know that this patient's 95% chance going to get those products. So at the end of the case, we would get those in the room in the cooler. Not that we necessarily have to give them, but we're prepared to give them immediately after the protamine if the case looks like it's a wet one. Then next time we check it is during the case when the cross clamp comes off. And this is just our protocol. You're welcome to use it as many times as you like. But once we take the cross clamp off, the perfusionist measures it again, and they quantitatively tell us the results. They say the platelets have dropped 50% from baseline. So that's telling me, okay, this patient's getting a little coagulopathic from the pump run. They're likely going to need platelets, or they'll tell me, the fibrinogen stayed pretty steady. It only dropped 5 or 10% from baseline. Then I know we're probably still looking okay. And then once we give protamine, we give any products that we were going to give already. Then we check our final one, and that lets us know how things are looking around the time when we're closing. And then if it's a bleeding patient, again, we can check this as many times as we need to. Let's say the platelets were low. We'd give 2 platelets, check it again, make sure it comes up, as opposed to the shotgun giving, 2 platelets, 2 cryo, 2 FFP because the tubes are still wet. So we can kind of tailor and target which blood product we need when somebody's bleeding. And then the ICU, typically we'll check it if the patient's bleeding. So in this day and age, usually we don't have to, but if the patient's bleeding, once they get up there, we'll ask the nurses to check this. Then they just text us this little screenshot if we're not at the bedside, and we can quickly and easily tell them what products they need to get. So algorithms, people oftentimes ask about, can you insert the Quantra into some sort of algorithm that, the team can automatically follow, which is hard. Of course, a surgeon's algorithm is just, do whatever I say, which is not the right thing. But I think it's hard to incorporate this into a specific, objective algorithm, just because there's so many variables during the case that are hard to, quantify objectively. So we try our best to do this. So in the beginning of the case, the surgeon pretty much tries to tell everyone how the hemostasis is looking just from the beginning. So just during opening, sternotomy, mammary takedown, just does this look like it's a bloodbath, or does things look pretty reasonable? Even our PAs, if they're in their harvesting vein, they'll tell us, hey, this tunnel looks pretty bloody versus it looks okay. So we use that in conjunction with the Quantra to know what we might need to have in the room. So for example, if the Quantra looks okay, but it's a 85-year-old redo double valve, and it takes me 25 minutes to dry up the sternal bleeding and the PA is drowning in blood in the leg, we may still get some blood in the room in that sort of case. So communication, with this in mind, and you guys know this already, but communication of this information and the whole bleeding situation is very key. So honesty, particularly from us as surgeons, there's a lot of ego in cardiac surgery, as you guys know. So if we aren't happy with an anastomosis, or we put a bad stitch in and something's bleeding, oftentimes we're hesitant to just announce that to the room. But I think it's important that we do, just to help delineate, is this bleeding from something surgical or something that could be surgical versus pure coagulopathy. Closed loop communication. So with the Quantra, having to convey those informations, for example, the one when we take the cross clamp off, we're oftentimes busy, but we all make sure that everyone's heard everyone. We call back and make sure it's not just perfusion to surgeon, but that anesthesia is engaged, the nurses are engaged, so the whole team knows what the status is of the Quantra. frequent and fluid, of course, and then having everyone in the room involved. Pitfalls, again, this stuff is mostly well known, but just not having callback, not having closed loop communication, not saying when you don't know or understand something, if you can't understand the Quantra, or it's a new nurse, not sure what blood products to get, or not sure to get it a cooler or not sure what can be returned. And then just, the whispering, you guys know, between perfusion and anesthesia, kind of talking about things as opposed to making sure the whole room knows. And same with the surgeon, us just telling our scrub tech we're worried about something instead of telling the whole room. So Quantra, the advantages that we've seen so far are, set points of testing via institutional protocols. So like we talked about, we check it before, after the clamp comes off, and then again after protamine. The results are really fast. We said about 5 to 10, 5 to 12 minutes. Quantitative results. So again, our perfusionists can objectively tell us how much the Quantra varies from baseline and how much it's dropped or increased during the case. And it's really, really easy to interpret, such that now during the case, I just look over my shoulder and I can eyeball it and just instantaneously know what it's telling me. Disadvantages, like I mentioned, a lot of patients are on blood thinners these days, so it doesn't always take into medication effect. So if someone is on Brilinta, it's an emergency case, their last dose was today, the Quantra won't necessarily show the platelet function to be really, really low. So you still have to, do your history, find out when the patient's last dose of blood thinners were to take that into consideration. So anecdotally, since we started using this in February 2021, what are we seeing? Well, one, I think it correlates really well with standard lab values. The easiest example is fibrinogen. So when we check this and the fibrinogen contribution to clot strength is really, really high, that usually correlates on the labs. The patient's fibrinogen is 300, 400, so unusually high. We notice that patients tend to bleed less post-op, less take back for bleeding. The trend we notice is that we're seeing more platelet and cryo deficiency in the OR. So we're getting on top of that early by transfusing more of that intra-op. But we notice that overall post-operatively less blood products are needed, less of these late unexpected bleeds at 2 in the morning when the tubes are dry initially, less hemothoraces in the morning after surgery. And one thing that this is pretty powerful for me is that when I go with the clinical picture, let's say it's dry, I'm closing up, I'm pretty happy with things, and the Quantra looks really, really bad. If I don't treat that in those cases, I would say at least 4 out of 5, I'm wrong, and the Quantra's right, and I end up giving 6 products post-op. And I think that's what proves to me that this thing is pretty good. Because me and my partners now, we know not to go against this thing because we'll usually get burned if we do. So our initial experience, so when we first started using this, of course, we wanted to see, how are we doing? How is this thing working? So we pretty much looked at 100 patients before we started using it and 100 patients after we started using it. And the cases for this research study were just STS index cases, so cabbage valve. And looking at both groups are pretty similar. The post-Quantra patients were actually a little bit sicker. If you look at the STS score there, it was a little bit higher. But one thing we noticed, which we were not expecting to notice, was that it looked like the times of the cases were a little bit shorter. So the bypass time, cross-clamp times, OR times are all a little bit shorter, which we were not looking for, but we were a little bit surprised to see. And tying that into the blood products, the total amount of blood products used during those 2 eras was lower in the post-Quantra era. So about 398 in the pre and 337 in the post, and that's for those whole cohorts of about 100 patients in each group. I mentioned the number of patients receiving transfusions was about the same, but just the number of products that they were getting overall was a little bit less. In terms of what products those were, the biggest things we noticed was that we were giving less FFP. So, in the old days, and maybe some of you guys do this now, but, patients bleeding, all right, let's give them a round. 2 platelets, 2 cryo, 2 FFP. And that was pretty knee-jerk for us. But now we notice with this is that we're able to tailor it much, much more better. So it might be 2 platelets, recheck a Quantra, and you might still be more platelets. It might be another 2 platelets because the Quantra shows you that the platelets were still below normal. So I think this has helped us tailor this, which is why the FFP transfusion rate is lower here. And post-op, we're seeing, using less red blood cells and less FFP as well, just because patients aren't bleeding as much. And then looking at other raw numbers, again, this was very early in the experience, but in the post-Quantra era, we had no takebacks or bleeding. The length of hospital stay was about a day shorter. AFib about the same statistically, and then mortality and renal failure were low, in both groups. So that was our kind of initial data. Now, again, it's been 3-ish years that we've been using this, so we decided to look at the whole core. So these are just my cases. So my cases before we started using the Quantra and after starting using the Quantra, and this is all cases. So this includes the 3rd time redo. This includes the robotic mitral. This includes anything on pump. Why? So here we had a large cohort, about 713 patients. It's about 350, 360 in each group, all cardiac surgeries. and we looked at our data. We looked at our clinical outcomes and the blood transfusion data. So one thing we noticed was that intraoperatively more patients were getting transfused in the post-Quantra group. So the number of patients who did versus didn't was higher in the post-Quantra group, probably because we're seeing more abnormalities and getting on top of it, where in the old days we would sit tight and wait till they got to the unit. But of those patients who received transfusions, less products were given overall in the post-Quantra era. So each patient, instead of getting on average 4, would get 2 for the patients who got blood products transfused. So looking at that in a little more detail here. So intraoperative transfusions here, we see the number of the first row you see there is the number of patients who got transfused, which we said was higher in the post-Quantra group. And then the numbers below that are for the patients who got transfused, how much blood products you get, and that's the median and the interquartile range in the parentheses there. So you see the platelet use was less per patient in this group, as was the FFP. The cryo is getting there with the trend, and then the total products transfused per patient was also less in the post-Quantra group. So post-operative, so once they got to the ICU, what sort of blood products are we getting there? So here the number of patients transfused postoperatively was the same in both groups, but same sort of trend here. You look at the numbers are very, very low across both groups, because most patients are getting 0 or 1 unit of blood, as opposed to a lot more in the past when it was more of a shotgun approach. And this, I think, is the most important thing, because again, we give blood not to keep the hematocrit up or make the chest tube stop bleeding, but we want to have, the main thing is that patients have a really, really good clinical outcome. And these are some of the clinical outcomes we've noticed here. So we noticed the cross-clamp times were significantly less in the post-era, procedure times were less, OR times were less, the ventilation hours you see there were significantly less, ICU length stay lower, total hospital stay length of lower, and the most important one here is the OR bring back. So it was statistically significant, much lower in the post-Quantra group. So, with this in mind, we've had some recent accolades in our program. So for the first time ever, this happened maybe a couple of years ago, that we got 3 out of 3 stars by the STS for all categories. So overall, mortality, LEMA use, all that sort of stuff. And then our program had never ever had it before for mitral, but we got it as well for mitral valve repair replacement. And the California Health Department, with public reporting, you can kind of get average, above average, or below average. Only 2 programs in the entire state get above average, and we were one of those 2 programs for CABG. So we never had that before. It's happened in the past couple of years. So I'm not saying it's due to the Quantra, but I think this allows us to do surgery pretty cleanly and avoid a lot of those complications post-op, which contribute to these star ratings. So limitations. So probably the biggest limitation of all this is behavior. So a lot of this is just the surgeon's decision making at the whim of the moment, and all surgeons are different. So some may not want to transfuse at all until they really, really have to. Some may transfuse against every abnormality they see from this Quantra device, and everything in between. So even myself and my 2 partners, we're all different in terms of our behavior and our threshold to transfuse. So how you pick that up in a study can be difficult. Then surgical bleeding. So it's not a binary event. So you can have an anastomosis with a squirter, sure, that's surgical bleeding, but you can also have not the best anastomosis that's oozing, and that may not be coagulopathy, that may just be bad technical. But if the hemostatic system was great, it may not bleed. But if it's medium or a little bit low, it may bleed. So again, it's not binary. So just characterizing as surgical or medical is, I don't think, accurate. And then heterogeneity of cases in patients. So you guys know all these cases are so different. The robotic mitral is very, very different from the redo dissection repair. So lumping those patients in the same group, can you do it? Sure, but there are probably some differences there that you're not picking up. If you just stratify based on each individual case, then the sample sizes get kind of low. So just having more of a sample size with time and able to analyze specific cases would be great. And then error effect, are these numbers better in the post because I'm getting better? I don't think so. I wish I was getting better at that rate, at this stage in my career. But again, there always an error effect is there. Are the anesthesiologists different? Is the equipment different? The answer is no, but there are probably confounders that we're not picking up that could be related to that. So in conclusion, so again, avoiding transfusion is important, but I think you have to weigh that carefully against the negative consequences of bleeding. And bleeding is more than just take back to the OR, retain blood, and higher transfusion rates if you don't transfuse early. The Quantra device provides a quick, reliable, really easy method to assess the patient's coagulation status before, during, after a case. And at our institution, since we started using this, we've seen some trends towards less blood product usage per patient, better clinical outcomes, and decreased surgical times. All right. that's it, and happy to take any questions.
Hi, wanted to say thank you for your talk. First of all, I'm Liz from IU, Indianapolis, and I was wondering if your institution used TAG prior to Quantra.
Yes, we did use TAG, and we still use it from time to time. And one of the things we don't like is just consistency. So sometimes it seems kind of way off from the clinical picture. Sometimes it seems accurate, but sometimes it seems really, really off, which is one of the reasons why we got into this. Because the anesthesiologist would say, the TAG looks really great, and I would open the sternum, and it'd take me 10 minutes to dry it up. So that's why we didn't like it too much.
Thank you.
Sure.
Hi, thanks for a great presentation. My name is Bruce Bronstein. I'm from Northern Nevada Sierra Medical Center in Reno. I have used competing products in the past, and they used two different cartridges for platelet function and citrated. This is only one sample, right?
Correct.
Okay. I'm also wondering about the runtime, typical runtime, and also the availability of commercially prepared QCs. The F.A.C.S requires phlebotomizing staff in order to do QCs. Is that a problem with the Quantra?
Yeah, great questions. So the QCs are done automatically on this. I believe I'll let the Quantra guys chime in, I believe every 8 hours. Yeah, 8 hours it automatically does it, so you don't need any of that. And then it's just one sample of blood, one cartridge. And time-wise, usually the clot time comes back first. So it's about 5 minutes, and then the fibrinogen and platelets, kind of 10, 12 minutes on the max time, sometimes even sooner. So it's pretty quick.
Excellent. Thank you.
Mm-hmm.
Any further questions? Here we go.
Our questions on the live chat are about quality controls and costs, and it looks like Julie's doing a great job of answering those in the feed. And I guess everybody else that has questions about those specific things could stop by the booth, right?
Mm-hmm.
Quality controls, costs,
Sure.
trials.
I will add, in addition to it running its own internal controls every 8 hours, QC is run every 30 days on this device, and that's it.
Dr. Shah, thank you. Thank you for the great presentation. I'm Isaac from Johns Hopkins. So in your slide, in one of the slides, you mentioned how to interpret factor deficiency, platelet deficiency, and fibrinogen deficiency. And also in few slides, you mentioned about algorithmic and quantitatively. So in my experience, when I worked with the different surgeons, different anesthesiologists, the quantification is the question when we know the deficiency. For example, if I know my fibrinogen level is like 80 milligrams per deciliter or 56 milligrams per deciliter, how to quantify if my threshold level is 120? Because what perfusionist we are doing during pump, we know exactly what volume we require, for example, RBC, if I want my hematocrit go from 30 to 35. So the quantification is algorithmically, it is calculated. But post-operatively, when it comes to the deficiency factors, still most of the centers or most of the healthcare providers giving a random dose, give 10 ml per kilogram or 20 ml per kilogram, do a test, get the result, again treat the patient. This prolongation keep the patient longer in the operating room, keeping the existing problem of bleeding. So do you know any specific calculation to quantify platelets and fibrinogen?
Just to make sure I understand your question, so you're saying you see a deficiency, how much platelet or cryo would you need to give to have it increase by a certain amount?
Yes.
Short answer is no. It probably could be done, but usually that all based on how far below normal it is. So where the green ends, if they tell me it's just below normal and it was a cabbage and I'm a little bit worried, I would just give 1. But if they tell me they'll say it's way below normal, 20% below normal, and it's a circa-rest case, then I would give 2. So, and that's probably the most we start with. We wouldn't do any more than 2 before rechecking. So I think your choices are 0, 1, or 2. So I think if it's a little bit low, we go with 1. If it's significantly lower and a bigger case, we would go with 2, and then recheck.
Thank you.
So, and that's the benefit, so that you get a result so quickly. So when the two are in, I let it circulate for 5 minutes, we'd recheck it. In that meantime, I would have another 2 platelets in the room in a cooler. We can always return them, and then there wouldn't be much of a delay before you knew if you had to give them or not. Just 5-10 minutes.
Thank you.
Sure.
So can I just chime in to help with a little bit of that clarity? So many of the institutions actually, when you ultimately adopt Quantra, you can go down that route, and some of them need more quantitative and need more numerical algorithms built in. So there's a lot of correlation between the pathologist, between the institution, as well as within HemoSonics to build in a credible algorithm numerically based to say for fibrinogen at 1.8 to 1.9 translates into X units of cryo, at the F.A.C.S equivalent of this translates into platelets. So numerically, if you're looking for a more concrete numerical value, that can be created, and we have large institutions that do adopt that. So it's truly at the discretion of the institution, but ultimately it comes down to where the preference of the institution wants to be and how stringent they want to be in this mode. It really depends on ultimately what's the culture of that institution and where they want to play in that space. Okay.
Thank you, officer. Any further questions? All right, well, if not, wish you guys a great day, great meetings, and please stop by the HemoSonics booth. Most of all, thank you, Dr. Shah.
Thank you, guys.